So now moving on to our next speaker. It is my privilege to introduce our next chief guest speaker, a world-renowned vision scientist, researcher, and respected academic figure, Professor Dr. Mark Bullimore, who has done FC Optom, MC Optom, PhD, Fellow American Academy of Optometry, and professor at the University of Houston, USA. Today, he will be discussing orthokeratology, an essential and evolving pillar of modern myopia management. Professor, we are deeply honored to have you with us. So the stage is yours. Thank you.
Thank you for that
And
kind introduction. I just need to attend to something. I'll be back in 10 seconds. So you can see my screen, I hope. So I'm going to be focusing on orthokeratology today, but also giving a slightly broader perspective. Before I begin, I'm affiliated with the University of Houston, but I make my living working with companies large and small. And of course, many of the companies you can see there have an interest in myopia. You see this QR code on the left. It's also on my background. If you scan that code, it'll take you to my website and it'll give you a list of recommended reading on myopia management. And some of the papers I'm going to talk about today are listed on there. Most of these papers are also open access. So why myopia? Why now? Because when I was studying optometry, we regarded myopia as a somewhat benign refractive error that we would treat with contact lenses and glasses, and perhaps more recently with laser refractive surgery. But things have changed for a number of reasons. We've heard about the increase in prevalence, and Mariam presented some very nice data in her presentation. We also have a better understanding of its importance and the role that myopia plays in uncorrected visual impairment. But finally, we now have the ability to do something about it. So we have interventions that can delay the onset of myopia and also slow its progression. Now, when it comes to looking at evidence, we like to see the highest quality of evidence. We live in an evidence-based world, and this is the evidence-based pyramid. And you can see at the top, randomized controlled trials. Now, there is actually even a higher level of evidence, which are meta-analyses, where multiple clinical trials are analyzed together. And of course, at the bottom, you've got expert opinions, which is a very low form of evidence. And then, of course, even below that, you've got social media and politicians that unfortunately we get bombarded by. So in terms of different interventions, we've just published this International Myopia Institute report on interventions for controlling myopia onset and progression. And the figure on the right is the sort of the big take-home message, where we compare the efficacy of a range of different interventions, be them spectacles, lenses, drugs, and red light therapy. And we also compare the efficacy within those categories. And I'll drill down a little bit on some of these, but I do recommend you take a look at that paper. So I showed you some graphs there, but let's get back to think about how we describe the efficacy of a myopia control intervention. Obviously, on the left, we can measure axial length, we can measure refractive error, and we would hope that they would be well correlated, but both are influenced by age and race of the patient. For axial length, we like to see optical biometry being used. We no longer use ultrasound in clinical trials. And for refractive error, the best measure we have is cycloplegic autorefraction. Now, in terms of defining efficacy using those values, we have a number of things that we can do, including sort of the proportion of children that progress by a certain amount, the percentage slowing. But the one at the top is what we want to really focus on: absolute changes. And the cumulative absolute reduction in axial elongation, or indeed refractive error, is really what we focus on. So this is a graph that Brennan and a few of his colleagues published, including me. And on the right, you can see the reduction in axial elongation. That's the efficacy of a myopia control intervention for a range of studies. And one thing you can see is that the lines aren't straight. You get a greater slowing or reduction in axial elongation in the first year than you do in subsequent years. And you'll see that on all the graphs I present later. So how do we get those graphs? So we start off with the figures that we see in every paper, showing the myopia progression at the top and the axial elongation at the bottom in both the treated and the controlled subjects. So we take the difference in axial elongation, say at 12 months and 24 months, and then we plot that on the graph. So that's how we get those those graphs of efficacy. And you can see that the lines continue to go up. We can add some additional interventions here. These are all different spectacle lenses. And you can see where there's multiple years of data, the slope is flatter in the second and third year. That is to say, the efficacy is greatest in the first year. Now, one of the advantages of using CARE, or the cumulative reduction in axial elongation, is that it's relatively unaffected by age. So I've given you two data sets here. The one on the left is from the LAMP study, a study of 3 different concentrations of atropine. And you can see, if you draw a line through the controls at the top in red, and just as an example, the highest concentration, the green dots at the bottom, 0.05% atropine, you see that the lines are parallel. On the right, there's a randomized clinical trial of red light therapy, and the authors have done the same thing here. They've plotted axial length changes as a function of age, and you can see that for both the red light and the single vision spectacle control condition, the lines are parallel. Now, the problem with percentages is that when you look at percentages, they are very, very dependent on age. So in older children, you can get complete sort of arrest of myopia progression and axial elongation. And that gives you percentages, of course, that are greater than 100%. Down at the bottom, you can see, on the left, you can see that the percentages are much, much lower. So percentages can be very misleading. So that's why in this paper, we focus on the absolute changes in axial elongation. And in the tables, we also give the values for myopia progression. So we have a number of myopia control options. These are the major ones. What you have access to depends on your scope of practice. And some of you can prescribe drugs, some of you can't. And also the availability of these products within your region or within your country. So let me just start talking first of all about overnight orthokeratology. So going back in time, and it seems a long time ago, but it was only about 13 years ago, Pauline Cho and colleague published the first study that really demonstrated the effect of slowing of axial elongation with overnight orthokeratology. And over a 2-year period, the children wearing overnight ortho-K, they elongated by about 1/4 millimeter less than the spectacle lens wearers. And again, if you look at the graphs on the left, you can see that most of the benefit actually occurs in the first 6 months. Now, the authors then went and did a randomized clinical trial, and they again found about 1/4 millimeter slowing of axial elongation over 2 years. And these results have really been borne out by other studies. One of the things that's remarkable that you can see on this graph is that when you look at the 2-year slowing of axial elongation with overnight orthokeratology, it's remarkably consistent across different studies in different countries using different lenses. And we see that, again, this is a figure on the right taken from our IMI review paper. And you can see generally the results are remarkably consistent. and much more so than other interventions. Now, some of the lines at the bottom where you've got less efficacy are actually most of them are in less myopic eyes. And this is demonstrated quite clearly in this study. This was a retrospective study of myopic anisotropes. So you've got children with relatively high myopia in one eye and lower myopia in the other. And you can see over a year, those wearing single vision glasses, it doesn't matter which eye you're looking at, the elongation's a little over a third of a millimeter, and it's the same in both eyes. In the children that were wearing HAL lenses, that's Essilor's Stellus lenses, there's a reduction in elongation in both eyes. Interestingly, on the right, though, with orthokeratology, you see a robust slowing of axial elongation in the more myopic eye and less effect in the less myopic eye. And we know from a number of studies that you need a reasonable amount of myopia in order to get a treatment effect or an optimal treatment effect. So just to compare that with other kinds of devices, let's just talk briefly about soft lenses. These are data from the MySight clinical trial, which was published about 6 years ago. You can see over 3 years, you've got a slowing of about 2/3 of a diopter and a slowing of almost 0.3 millimeters of axial elongation. And what you can see in both the treated and the control populations, you see a correlation between axial elongation and myopia progression. More recently, a large randomized clinical trial of almost 300 children, they randomly assigned children to either wear a high-ad, center distance multifocal contact lens, a medium ad, or single vision. And one of the remarkable things about this study is that 98% of the children completed the 3-year study. What you can see is both for axial length and for myopia progression, there is a slowing of growth or slowing of progression with the high ad. So you've got almost a half a diopter slowing and about a 1/4 millimeter slowing over 3 years. The medium ad was less effective and not significantly different. So if you're going to use a center distance multifocal, then obviously going for the high ad. And again, these are data from both those two studies. You can see the red and the orange lines at the top are from the two studies I presented, and the blue line at the bottom is for the medium power ad. Those are the only studies with 3 years of data in a randomized clinical trial. But you can see a range of efficacy. So again, I encourage you to go back and take a look at these data here. If you were to sort of cherry pick and look at the best cases from each category, you can see that down the bottom, 0.01% atropine and progressive addition lens spectacles are generally not very effective. But then in the middle, you've got a range of options, including Ortho-K and dual focus contact lenses that are very effective. The most effective is red light therapy, but in its current incarnation, I regard it as unsafe and don't recommend using it. In terms of which treatments are best, I get often asked this. It's like asking a mother, though, which of her children she loves the best. My answer is always the same, regardless of who's asking me the question. It's the one that the child will use. And of course, there's a bunch of considerations that we talk about in this paper, including safety, comfort, vision, lifestyle, but really compliance is the most important aspect. So the most important aspect of myopia control is choosing something that the child will use. So I leave you with this fairly busy slide here. This is what I call the continuum of myopia care. And I've mainly sort of talked about number 6 in the middle of there, but we also need to pay attention to myopia in a very young child. We need to pay attention to predicting who's likely to develop myopia and intervening. And later on, we need to think about how long we're going to actually treat a myopic child and even potentially managing progression even into myopia. So I thank you for your attention. It's been a pleasure to talk to so many friends around the world this morning for me. I know it's in the evening in Bangladesh and Pakistan and that part of the world. I'm easy to find, bullers2020@gmail, or bullers2020.com is my website. I'm happy to share a PDF of my presentation if you would like, but I would encourage you to seek out some literature on my website and continue in your education. So I'll pass you back to the organizers now and stop sharing my screen. There we go. And again, there's the QR code if you would like that. Ikra, back to you.
Yeah, thank you very much, Professor Mark Bullimore, for that exceptional session. Thank you so much.